Welcome you to yet another session of the Clinical Neurology Forum. And it is my great pleasure to have Professor DRS as the chairperson for this session. Professor DRS, as all of you know, has been always associated with the neurology department at Madurai Medical College. Even before he joined DM, he was working in the neurology department as assistant to Professor KS. And he has not only been an assistant to Professor KS, he has been the right hand to Professor KS and accompany KS wherever KS goes. And he has lent him a helping hand right through. And as I said, it's my privilege to have Professor DRS to chair this session. And we have presentations from PSG College, Medical College, Coimbatore and Hospital Coimbatore. Professor Balakrishnan and his associate consultant, Dr. Mohanakannan, will be presenting cases. And I request Professor DRS to conduct the proceedings from now on. A word about introduction about Professor Balakrishnan. As he just told me, he was an undergraduate at Bala at where did you do your
PSG, sir. PSG.
At PSG Medical College. Did his MD at
Coimbatore Medical College.
Probably
Coimbatore Medical College. Sir.
Coimbatore Medical College, and then did his DM at Madurai Medical College. Mohana Krishnan has been DM graduate, postgraduate at Madurai Medical College.
No, sir. Stanley,
both of them.
No, Stanley, sir. Stanley.
Oh, sorry. sorry.
Yes, sir.
I did his DM at Stanley Medical College, and I hand over to Professor DRS to start, initiate, and conduct the proceedings. Professor DRS, sir, you may go ahead.
Thank you, Dr. Natarajan. So nice of you to organize this. I'm extremely happy to participate in this event. This has been the most popular event. Every month you conduct this with a lot of strain taking. This is must be much useful to most of us because we learn from our own students. Because of the latest developments, etc., students so much better than teachers now. So with that introduction, I request Professor Balakrishnan to start his presenting his case on special
interesting case of neuropathy, sir.
Neuropathy.
Thank you, sir. Thank you, sir. Thank you very much, sir. So slides are visible, sir?
Yes, sir.
Sir, yes, sir. Sir, I think we all come across the case of peripheral neuropathy, I think, in our day-to-day practice. This is the patient which maybe probably has maybe challenged probably my clinical knowledge and my treatment also. And I had to get maybe another opinion as per the patient's relatives also for the final diagnosis. And anyway, I'll just go through the small this thing. So this is about 26-year-old female, and this is a 4 years history of any neuropathic symptoms in both lower limbs, from shoulder to hip, progress to over 3 to 4 months duration. Same time, she also had sensory symptoms in both hands up to the wrist. And symptoms suggest a small fiber and large fiber neuropathy. And there is history of slippage of chapels. And she didn't have any weakness initially. And she was treated with, as peripheral neuropathy with some improvement in the neuropathic symptoms. And she has met probably a few neurologists in Coimbatore. And she had some improvement, and she was going on with the treatment. But when she came to us, I think it's 4 months symptoms of difficulty in walking. And the more than the weakness, I think she has grossly ataxic. And sir?
Sorry, continue.
Yes, sir. She has severe ataxia. So she was not able to even get up from the bed and maybe able to stand, walk, even few steps. And she was not able to eat also. And she also had numbness of the face also. And she also had defective vision in both eyes for 1 month. And she was admitted for evaluation. And she was conscious, GCS 15/15, speech was normal. Cranial nerves were normal except for defective vision, but pupils were normal, no RFPD, fundus was normal. And motor power is almost 4+/5 in all 4 limbs. DTR is absent in all 4 limbs. And sensation impaired touch in both lower limbs up to the knee and up to the wrist. Impaired vibration up to iliac crest and the wrist. Joint position sense are absent in the toes, ankle, knees, and the wrist. Gait, severe sensory ataxia. She was not able to even stand with 2% support. So there is no history symptoms list of any like arthritis or any oral ulcers or malar rash or no other symptoms list of any vasculitis or malignancy. So this is about this 4 years history of length dependent small and large fiber neuropathy, and probably worsening in the last 4 months, and grossly preserved motor power, absent DTRs in all 4 limbs, and loss of touch, vibration, joint position sense, and severe sensory ataxia and with facial sensory loss. I missed one findings in this because if I tell that finding, I think all of us will tell the diagnosis. So I think I can invite probably not my teachers, my probably students is participating in this forum can probably try to answer maybe the question for the diagnosis.
What about the difficulty in swallowing, you said?
No, sir, no bulbar symptoms, sir.
But you said there's a difficulty in swallowing.
No, sir, no swallowing difficulties, sir.
It's only numbness of the base.
Predominant sensory symptoms with gross ataxia, sir.
Gross ataxia.
What was the visual symptom, Bala?
Sir, I have some diagnosis for that also, sir.
No, but what was the symptom? What was the symptom? Visual
Sir,
symptom?
she was not, probably she had some blurring of vision. But
Both
vision
eyes.
is both eyes, sir. 6/6 vision.
Fundus normal.
Fundus normal, sir. No peoples are equal. No RFPD and ophthalmologist. They made a diagnosis later only after we have probably told them this. We have to look for this. And
hearing normal.
Hearing normal, sir. Hearing normal.
Is the person worsening or?
Yes, sir. Actually, 4 years history worsening for the last 4 months.
4 months. There is no bladder symptoms.
No, sir. Bowel and bladder normal. And maybe evaluation, I'll tell you, sir. I think this is it's a neuropathy, sir. What I am presenting is not a myelopathy, sir. It's a neuropathy.
It's an ataxic neuropathy.
Yes, sir.
With an absent reflexes.
Yes, sir.
Symmetrical.
So it's distal at the ganglion or distal to the ganglion.
Yes, sir. So
And
anyway,
ataxic neuropathy.
yes, sir. I thought some students will answer, sir. Anyway.
Is symmetrical? Is it symmetrical?
Yes, sir. Symmetrical, sir. Symmetrical, sir.
Proximal more than distal.
Yes, predominantly length dependent distal, sir. Distal lesions.
Bala, there's already an answer in the chat box.
Oh, I think somebody's answered, sir.
Bollocks, any history of any dry eyes, dry mouth?
No, sir. No, sir. No, sir. No, sir. Yes, sir. I think there are a lot of answers. I think 3 people have answered, sir. Anyways, good. So I'll progress, sir. I'll just go to the next slide.
Can you read out what was the answers? Because
okay, sir. Okay. Okay. They have, I think, Anama Maniyar, I think, sensory ganglionopathy, Vignesh Shantanam ganglionopathy. So this is our initial thoughts also. I think this is correct.
Etiology. They should also proceed towards etiology.
Yes, sir.
If possible.
Yes, sir. I'll show the video of the patient. Probably after 2-3 months of probably rituximab also. I think this is not opening. I think there's some problem. I'll show the video separately, sir. I'll show the video separately.
Hello, one minute. Yes. Sorry. You said sensory ataxia.
Yes, sir.
What does that mean? The patient was ataxic.
Yes, grossly ataxic, sir.
Yeah, then why do you say small fiber neuropathy?
No, sir, she had a pricking pain also. Pricking pain.
Okay, but certainly the large fibers are involved.
Yes, sir. Predominantly large fibers are involved, sir.
Yes. Okay. Thank you.
I'll show the video a little later, sir. I think it's not opening. So evaluation, we have done protein blood investigations, C3, C4, ANIF, ANA profile, ANCA profile, electrophoresis, paraneoplastic antibody panel, everything is negative. And this is MRI done in probably July before she came to us. MRI brain and spine was normal. Oh, NCS is not opening. Oh, sorry, sir. I think NCS is not opening. I'll show the NCS little later. No, it's not. Okay. NCS was showing a normal motor C maps. Snaps, everything is absent, sir. So, so we did a now biopsy, sir, and probably in the 7th month, showing a typical chronic axonal neuropathy, likely immune mediated because there is some evidence of inflammatory cells in the nerve biopsy. So then we went ahead with maybe a PET scan also. Whole body PET is there is no negative, and then we started the patient on steroids and then IVIG followed by 2 doses of rituximab. So patient had a poor response to all the treatments. She never had any good response to either steroids or IVIG or even rituximab 2 doses. And she continues to be in the probably some minor improvement in the gait. If I show the video, I think all of you will understand. And another thing is they wanted, because they're off Malayali, they wanted another opinion. So they went to Thiruvananthapuram to meet Dr. Madhusudan sir. So I think they in the month of 9th month they met him. So he has also made a diagnosis of chronic sensory ganglion and neuropathy. And the cause of vision loss is neuropathic keratopathy, sir. So ophthalmologist showed evidence that there is evidence of keratopathy. Corneal sensations are lost. And because of the corneal sensation loss, she has neuropathic keratitis. So that is why I think she has evidence of poor vision, sir, this patient. So,
Bala,
yes,
at this stage, see, we are still only talking about the anatomical localization of a sensory ganglionopathy.
yes, sir. Yes,
But
sir.
we have not talked about the cause. Why does
Yes,
she
sir.
have this? So, what was the thinking about that? Both you and Madhu, both of you have not said anything about the possible cause. Of course,
Sir,
your
actually,
treatment schedule suggests that it might be an immune mediated, or it could be paraneoplastic. But further investigations towards the cause, of course, maybe you come towards investigations later. I don't know.
no, sir. No, sir. Sir, we have ruled out vasculitis, sir. We have ruled out Sjogren's. We did a Schumann's test. We do any lip biopsy. We have ruled out all this C3, C4, vasculitic workup, ANA profile, ANA, IF, everything we have done, sir. Extensive workup.
What about the CSF? What about the CSF?
Yes, sir. CSF showed only 20 cells, normal protein, sir.
But not elevated protein.
Proteins were normal. Proteins were normal, sir.
No.
CSF was normal, sir.
Okay.
CSF was normal. Vasculitic workup is negative. Paraneoplastic antibodies negative. PET scan is negative. And we have done an extensive vasculitic workup, sir. Extensive. I think we are 4 people at that time. So I think everybody has seen the patient, and we have had inputs from all of them, and we evaluated accordingly. But
And the nerve conduction study showed an axonal neuropathy.
yeah, sir, I'll show you, sir. Just a minute, sir. I'll show you the. So I'll show it in my this thing, sir. Oh, somehow it's. Oh, sir, can you see my slide, sir?
पीपीटी डाउनलोड करके तो ओपन करिए सर.
Not open. It's not open.
सर पीपीटी ओपन करिए सर.
I'll stop sharing and I'll just do it again.
Hello, Balkishan sir.
Yeah, I'm just opening this thing. Just a minute.
Okay, sir.
Can you see this thing?
You will have to zoom it. You
So
will have
I'm
to
out.
zoom it.
Yeah, I am out. Can you see the slide?
Then I would not see that.
No,
Just a
Bala, you
minute.
have to zoom it.
Yes, sir. I'll do it, sir. I'll do it. So this is motor nerve conduction, sir.
Yeah.
And the sensory I'll show you, sir.
What sensitivity was it? 500 microvolts?
Yes, sir. Yes, sir. And this is the all snaps, sir. You can see only motor this thing, sir. There is no snaps or pens, sir. Sorry, sir. I think I added, but I think so. This is a sensory nerve conduction study, and showing this absent except for small ulnar potential.
Okay, motor conduction, what was the distal latency and what was the F wave latencies?
Okay, sir. Sir, I think it's all around 3, sir. 3.5 in median. Ulnar is 2.8 and the peroneal is around 4, sir. And tibial is 4. Motor conductions are all lower limbs around 43 to 45, sir. Upper limbs are around more than 50, sir.
And F wave latencies?
FIV latencies are normal.
Okay, okay.
FIV latencies are around only 24 in upper limbs, 50 in lower limbs, sir. It's all normal.
So essentially, it's a sensory neuropathy was what you found on the nerve conduction.
Yes, sir. Nerve conduction wise, it's all snaps are absent with normal motor response, normal latencies, normal conduction velocities, and normal FIV latency. So it's predominantly it's a sensory neuropathy, but correlating with
Symmetrical.
yes, sir, symmetric and correlating with the clinical history, probably we could make a diagnosis of a sensory neuronopathy. The etiology for this neuronopathy, I think we evaluated maybe like as I told you earlier. We have evaluated for vasculitis, we have evaluated for malignancy, we have done even CSF, we have done a nerve biopsy, and probably we couldn't identify the cause for the neuronopathy. So what we thought is it's a idiopathic sensory neuronopathy, ganglionopathy, presenting probably over a period of 4 months with acute worsening for the last 4 months. That's why I had a doubt whether I'm missing out anything. And the patients are all well-educated family. They also wanted a second opinion. Even they have gone to some Bangalore hospital also after they have maybe we have started treatment. They went to Chennai also. They have met a lot of neurologists, and everybody is told I think it's maybe rituximab is the final thing. And I also want inputs from maybe my teachers and from students. Probably am I missing anything in this patient? And whether there any other treatment options for this girl, because if I show the video of the disability, I think all of us will know that she's. I think I'll show the video, sir. I'll just go out of this thing, sir. The slide sharing, and then I'll leave. I'll add. Can I see the video, sir?
Yes, nobody has come. Yes.
See the severe disability, sir.
Yes.
She's grossly ataxic, and the husband is holding her for even for walking, sir. Sorry
Has
for
she
the
got a-
sorry for
Has
the
she got a foot
quality.
drop also?
Actually, the power is almost normal, sir.
Uh,
And and there is pseudoathetosis also, sir. That's, I think I missed it in the. I didn't mention it.
So bone marrow done, Bala?
No, sir. We didn't do bone marrow, sir. We didn't do, sir.
Any possibility of celiac disease and neuropathy?
It's okay, sir. But we have. She had a slightly raised globulin, sir, and ultrasound mildly raised SGPT. And we have evaluated. We have asked our gastroenterologist to evaluate her, and they have seen 3 to 4 times, and she didn't have any diarrhea, sir. So this is definitely one possibility, sir. Celiac disease with maybe sensory neuropathy, and so this is a gross motor, maybe sensory deficit she has, sir. So any other
And,
input, sir? Because
Dr. Bala, could it be syphilis? Did you check for CSF VDRL?
sir, I
HIV?
didn't. Sir, I didn't. HIV is done, sir. HIV is done. Routinely we do for all our
Syphilis.
patients. Syphilis, I didn't do, sir. I didn't do.
And bone marrow, sometimes a low-grade B-cell lymphoma can produce exactly similar symptoms, which is confined only to the bone marrow.
So the
Low-grade B-cell lymphoma.
history is around 4 years history, sir.
A low-grade B-cell lymphoma can exactly mimic these findings.
Sensory neuropathy, sir.
Yes, one particular case exactly. We did bone marrow biopsy and picked up a low-grade B-cell lymphoma.
Okay.
Did she have B symptoms, night sweats, fever?
No, sir. No, sir. No, sir. No, sir. She is totally asymptomatic. She never had any symptoms. Other than
No
Since you
loss of
told since
no
you told
loss of
keratopathy is
neuropathy, she had a
syphilis.
neuropathy keratopathy, sir.
Yeah, syphilis also.
Okay, sir. Anyway, I'll do a VDRL, sir. No, I'll definitely do it.
I take it there was no anemia.
So no anemia, sir. No anemia. No anemia. We have done a B12. We done a folate, sir. We have done everything, sir. We have done maybe evaluation for this neuropathy.
There's no lymphadenopathy anywhere.
No, sir. No, sir. No lymphadenopathy. That's why we had a suspicion of malignancy. That's why we did a PET. But sometimes PET also can miss malignancies. I agree. So we didn't do a bone marrow. I didn't do maybe a syphilis workup. Yes, immunofixation done. CSF, serum electrophoresis with immunofixation done for this patient. I think somebody has asked some questions.
And you already said that paraneoplastic panel was done.
Paraneoplastic antibody panel is negative, sir. Negative. We have done extensive workup, sir. I think for this patient, I think.
Yes.
Hepatitis B and C ruled out.
Yes, sir. Hepatitis B. Usually we do hepatitis B, C, HIV for all patients admitted with us. Because I burnt one time because after blood transfusion, one patient became positive. We didn't know the status before transfusion, so we made it routine to do it for all patients admitted. We explained them. This neurological illness may be because of retroviral disease, so I think we'll ask them to do all the routine investigation, all the 3. So the thing is, sir, I think maybe I have read it after the words. If it is a idiopathic sensory neuropathy, I think if the treatment started within 6 months of maybe the disease, I think the improvement will be better. So if the disease duration is longer and even whatever the treatment I think we give, I think there is not going to be any good response to the treatment. So that is what I think been described. So
Bala, any clues from the keratopathy side?
No, sir. I think there is a lot of punctuate maybe keratopathy because of this sensory loss, sir. But no clue, sir. No clue. Maybe probably she is not fitting into like lancinating pains like in tertiary syphilis. But anyway, I'll have consider this Maybe in young strokes we do VDRL, but this patient I didn't do the VDRL, sir. So I
Any
think-
sensory ganglionopathy, I think syphilis is a differential always.
Yes, sir.
Dr. Bala sir, Satish here.
Yes, Satish.
Among the immune-mediated neuropathy, have you done anti-MAG, anti-GAD, anti-silal antibodies, and other things? And sometimes even hereditary workup also, genetic workup. That is the only clue left behind, apart from toxins.
Okay, I didn't do any antibodies. Anti-MOG, I think is not a clear-cut.
No, anti-MAG, MAG.
Myelin associated glycoprotein.
Yes.
Yes, I didn't do.
And anti-silal antibodies. There are some, I think Amrita does that. So we can send it once. And also we have to do for the hereditary mapping for chronic CASP. So some hereditary, even there is no hereditary disorders, we can prove that.
Okay, you were like
Myelin associated glycoprotein antibodies can be seen in CIDP. Some types of CIDPs you can find that. Anti-MAG.
Okay. We can just send for a whole genome sequencing, I think, and the antibodies. I think I also read up after this this thing. Some genetic component is also there for this kind of sensory ganglionopathy. I think I'll do it, sir. Thank you, Satish.
How do you proceed further now?
So this patient was has received IV methylprednisolone for 5 days, followed by, I think it's IVIG also we gave, and there is not much of improvement. We gave rituximab, sir, 2 doses, 2 weeks apart, 1 gram, and patient had some slight improvement. And when she came to us, she was much worse. She was not even able to stand with even with 2% support. Now at least she's taking some few steps with the 1% support. So I'm also very clueless about further treatment, sir. So I think
only a follow-up will know what is going to happen.
yes, sir. Yes,
Still,
sir.
Still it will be hidden malignancy somewhere, which may come out later.
Yes, sir. I'll do a bone marrow, sir, and I'll maybe look for celiac antibodies, and I'll do a VDRL, and I'll maybe do a genetic testing, and I'll maybe share it in the next probably the neurology forum, and what is the follow-up of this patient, sir. Thank you, sir.
There is no neuropathy in the family.
No, sir. No, sir. Everybody is fine, sir. No positive family history. There is no positive family history, sir.
Interesting case, Bala. Interesting case, yes.
So I thought it is idiopathic. Anyway, I'll definitely try to rule out maybe anything treatable and genetic causes. Probably, I think these are the 2 things I have missed. Anyway, I'll just look for anything treatable. And thank you, sir. Thank you.
Thank you, Bala. Thank you very much.
Yes, sir. Somebody is saying something, sir.
Yeah, my question is, when there is no evidence for any immune-mediated, it is right to start the rituximab in these situations.
Sir, actually, nerve biopsy, sir. There is evidence of inflammation, like inflammatory cells are present in the nerve biopsy. Though it's not a typical of this thing. Actually, I discussed with the patient family, and I discussed with the Dr. Madhusudan sir also. So I know, sir, there is no clear-cut evidence of like demyelinating, immune-mediated neuropathy. I agree, but most of the time it's idiopathic sensory ganglionopathy. I think when there is no response to maybe steroids and IVIG, probably I think patient's family also they're asking for rituximab, and I discussed with probably I think 2 neurologists, and they are also concurred with maybe starting immunosuppression like with rituximab. That's why I gave, sir. So probably I'm wrong, but after maybe giving rituximab only, there's probably we could see some minor improvement. So
Dr. Bala,
yes, sir.
Dr. Bala, bone marrow with the flow cytometry to rule out a low-grade B-cell lymphoma, because you also said that it partially responded to rituximab. So it could very well be a low-grade B-cell. We had a particular case, similar, exactly what you described.
Okay.
Bone marrow with flow cytometry.
But what made you to think to do a bone marrow, sir?
that is one
long-standing
of the.
teaching. Professor DRS always says, if any neuropathy that fails to improve, you should rule out lymphoma.
No, sir. There's any like fever, night sweats, like these symptoms in that patient, sir?
In spite of that, I think Professor
Okay, I'll do
DRS
it.
would have
I'll do it.
forgotten, but he has taught us this.
We'll,
Any
we'll,
GBS, if it's recurrent, he says.
I'll do
Bala,
it,
when
sir.
you're looking out for a cause and we do not know the cause, I think bone marrow is an indication to look out for.
Definitely, sir. I'll do it, sir. I'll do it, sir. Yes, sir. Thank you, sir.
Thank you, Bala. Thank you.
Yes,
And
sir.
I think anybody would have gone in for rituximab because we do not know the cause and we need to give some treatment. So, yes, there is no reason why you should not have given rituximab. There is no need for you to feel sorry about it.
No, sir. I discussed before giving this because anyway, whenever I go for some maybe higher therapy like cyclophosphamide or rituximab, we always explain in detail the pros and consequences of this therapy. Then only we get a full consent in written in Tamil and English. Then
Was
only
IVAG given?
yes, sir, given, sir. Given, sir.
Okay.
Yes, sir.
Thank you, Bala. Thank you very much.
Yes, sir. Thank you, sir.
You have done all the work. You have done well.
Yes, sir.
When many other neurologists also consulted, nothing could be found out. Only follow-up measures can we know what is happening. As Vijayan said, we can do a bone marrow. And still a possibility of some hidden malignancy is always there. But the person looks very young. So we don't know what sort of malignancy do this. Still, that's going to be the final answer, is what I think. Bilateral, symmetrical, progressive, not responding to any other drug. This what's gloss ataxia involving both fibers. I think only follow-up measures can say. Possibly next forum you can tell us what has happened to the patient and what is the.
Yes, sir. I'll tell you the next meeting. I'll tell you, sir. I'll do all the investigations.
Thank you, Bala.
Yes, sir.
Professor DRS, sir.
Okay.
Mohana Kannan, sir.
I can invite now Dr. Mohana Kannan to present this case of dilemma.
A series of
Neurological
cases.
dilemma.
He is presenting a series of cases.
Silence for a long time.
Mohan?
What join mantara?
No. I'll call him, sir. சரி அதான் உங்களுக்காக வெயிட்டிங் எல்லாரும் ஓகே 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 sir, he is joining, sir. He is joining, sir. He is joining, sir. I think he is asking us a minute.
Water.
Mohan has joined, sir. Bonds, you're in silent mode. You have to switch on the mic. Yeah.
Welcome, Dr. Mohan Kannan. We are able to hear you.
மோகன் கேட்கல நீங்க பேசுறது கேட்கல.
நீங்க பேசுறது கேக்குது எங்களுக்கு.
சார் நான் பேசுறது கேக்குது சார். மோகன் பேசுறது
இல்ல கேட்கல.
Audio is not. It comes as audio negative.
மோகன் audio is not hearing. Just
Now
pause.
now you are connected to audio now.
Yeah.
That's right. What happened there? Sound is not.
Mohan sir, not audible, sir. Your voice not clear. Sir,
Voice
please,
is not coming through.
sir, Mohan, please leave and rejoin, sir. Mohan sir, not audible, sir. Mohan sir, please leave and rejoin, sir.
my PPT. Sorry for the delay, sir. I think I'm sorry for the delay. I'll just share my PPT. Just hold on. I've connected through my mobile. I'm not able to. Sir, I'm not able to open my PPT, sir. Is it not? Should it be a PDF document or? Okay.
Or you can send it to some maybe the tech support group. They'll open the slides for you. You can send
Sir, the file is too large to send, sir. I tried to send it already.
Oh,
I'll try to open via my laptop again, sir. Just hold on. Sorry for the inconvenience caused, sir, everybody.
I think you can start presenting, sir.
So 1 minute, sir. I'll just open the slides. 1 minute. I'll just hold on. I'll just open via my laptop. Yeah, 1 minute.
Meanwhile, Bala, can I ask you a question? Bala,
Yes, sir.
are you there?
Yes, sir, I am there, sir.
No, I just wanted to know. Of course, we were talking about idiopathic sensory ganglionopathy.
Yes, sir.
How often do we come across? Because of course, neuropathies we know about 40%. We may not find the cause.
Yes, sir.
That is getting narrowed down now with more investigations.
Yes,
What
sir.
do they say about idiopathic
Around
ganglionopathy?
more than 50% are idiopathic, sir.
More than 50 are idiopathic.
Yes, sir. More than 50% are idiopathic, sir.
And any mention about the treatment for those idiopathic?
There is no clear-cut regime, sir. But this has been advised. Probably no like studies, but it's all personal experiences and this thing, sir. I think Mohan has joined, sir. I think we'll allow them to. Yes.
Mohan, you are ready now?
Voice is not clear. No, you're not audible, probably.
He is not audible at all. But he is very much visible now.
Audible now, sir? Audible now, sir?
Lot of noises.
Sir, audio not clear, sir.
Oh. No, you're not audible.
Audible now or there's a lot of noise here?
Lot of noise is there.
We can hear, but there is some noises there. I think you can start doing more. I think Patu.
No, slides are visible.
Yes, slides are visible.
Audible? Audible?
Not
Noise
audible.
is there.
Slides and I'll talk via the phone, sir. So,
Sir, can you please remove
what am I supposed to do, sir?
leave computer audio? Your yes.
Okay, okay.
So otherwise echo is coming.
Okay, now I muted the computer audio, sir. Is this okay now?
Yes.
Yeah, it's okay.
Okay, fine. I'm sorry for the inconvenience. So I'm Dr. Mohan Kannan, consultant neurologist. 1 minute, sir. I'll just mute the system audio. Okay. So I'm Dr. Mohan Kannan. I'm a consultant neurologist in PSC Hospital in Coimbatore. First of all, I'd like to thank Dr. Natarajan sir for giving me this opportunity to present challenging cases in clinical neurology. Here I'm trying to present some of the difficult cases I faced, difficult scenarios I faced in my past 3 years of clinical experience in PSG Hospital. So going on to the talk. So first of all, I'd like to thank my teachers in Stanley Medical College Hospital, where I did my DM neurology. Somni Madam, Shakti sir, Malcolm sir, Arnand sir, all whom under whom I had trained, and without whom I would not be where I am now. So going on to the first case. So this is a 40-year-old female. She presented to us with 6-month history of difficulty in getting up from squatting and climbing stairs. And she also had recurrent episodes of abdominal pain with vomiting, which would last for 3 to 4 days, and she would get treated in a nearby hospital with supportive care. She had complaints of diffuse muscle pain. There were no other sensory symptoms. She was born of non-consanguineous parentage. She had her mother told a history of global developmental delay, and she had borderline intelligence and mild mental retardation according to her mother. She was non-married. Examination revealed MMSE of 25/30. She had slow saccades on examination. Tone was normal. Power was 3/5 in upper limbs proximal power and 2/5 in proximal in lower limbs. Distal power was normal. Reflexes were present. Sensory examination was normal. She had ataxia in upper limb on finger nose testing. Gait we were unable to test because the power in lower limb was only 2/5. We went ahead with the investigations. Routine blood investigations were normal. CPK was normal. Lactate, ammonia was normal. Echo, NCS was normal. We went ahead with an EMG because she had proximal muscle weakness of both upper limb and lower limb, which was of subacute to gradual in onset, and it has been progressive over the past 1 year, and it revealed a myopathic pattern. So we went ahead with the muscle biopsy. This was what the muscle biopsy revealed. And the muscle biopsy was suggestive of a lipid storage myopathy. So So the patient had multiple systems involved in the form of myopathy. She had myopathy. Also, she had some amount of ataxia in upper limbs, and she also had recurrent episodes of vomiting and abdominal symptoms. We thought it could be some sort of metabolic crisis she was undergoing. So then when I went through the literature and found this was a whole lot of lipid myopathies and which is present, and so there were a lot of types of workup to go through. Either we could go through a blood and urine workup where we sent for all the organic acid workups, acyl carnitine workup and all, but they were not financially affordable to go through, and it had a lot of steps. So we just went for genetic analysis directly. The gene analysis came as glutaric acidemia type 2C. So it is an inherited metabolic disorder where there is a difficulty in breakdown of proteins and amino acids. It's essentially a deficiency in two enzymes, so ETF and ETFDH. So there is difficulty in breakdown of proteins and fats and leads to increase in organic acids in the blood. So usually there are three types of glutaric acidemia type 2. So it could be either neonatal onset, or it could be a late onset, or it could be an intermediate onset. So here we had a patient who had presented to us with late onset glutaric acidemia. So basically there is accumulation of lot of fatty acids and proteins in the body. And so these are the types. The neonatal onset, it presents with congenital anomalies, non-ketotic hypoglycemia, metabolic acidosis, excretion of large amounts of fatty acids, and amino acid derived metabolites, and the patient may die in the newborn period. They may not go past the newborn period. Type 2 is neonatal onset without congenital anomalies, and type 3 is the late onset. So this patient had a type 3 or a late onset form of glutaric acidemia. Okay, so a lot of case reports were present. We went through the literature and found delayed presentation of late onset glutaric acidemia, and presenting as solely myopathy. So without other organ involvement, we did an echo. It was normal. She didn't have any cardiac involvement. She had mainly it was a myopathic presentation of glutaric acidemia type 2. So approach to a lipid storage myopathy. Basically, when you know it's a lipid storage myopathy, you can go ahead with an enzyme testing. So you do blood carnitine, acyl carnitine profile, or urine organic acid testing. But the confirmatory would be a genetic testing. So we went ahead directly with genetic testing. And here the patient had a lot of episodes of crisis. She had vomiting, abdominal pain. And so the precipitating factors for crisis are usually worsening of underlying disorder, or prolonged fasting, any excessive aerobic exercise, infections, and cold exposure. So how do you treat a crisis spell? Usually we give saline glucose solution administration and monitor the other parameters. So what I did to the patient, we started her on carnitine, riboflavin, high dose carnitine 2000 mg per day and riboflavin 400 mg per day. And we started her on high carbohydrate, low fat, and low protein diet. The cornerstone of this metabolic myopathies or the inherited glutaric acidemia type 2C, when we went through literature, was mainly dietary change. And this patient especially had a ETFDH mutation. So this especially is a partially riboflavin sensitive myopathy, ETFDH mutation. So we went through the literature and found it responds well to riboflavin. So we gave her a high dose of riboflavin 400 mg per day, carnitine 2000 mg per day, and we put her on CoQ10 600 mg per day. And she responded well. Now it's been 6 months since she's been on this, and the power has gradually increased. Her power now is 3/5, and she's now able to walk with minimal support. Her episodes of vomiting and abdominal pain has come down. So this is the multiple acyl-CoA dehydrogenase deficiency, or glutaric acidemia type 2C. So basically the majority of the gene which is found in this MAD or glutaric acidemia type 2C was ETFDH. That is what was isolated in our patient also. And there are three types, as I told, in glutaric acidemia type 2C. The neonatal onset with congenital anomalies, neonatal onset without congenital anomalies, and the type 3 is the late onset with predominantly muscle weakness and episodes of crisis or rhabdomyolysis. In our patient, CPK was normal. And these are the various manifestations you can have in glutaric acidemia type 2C. They can have metabolic decompensation, musculoskeletal in the form of myopathy. They can also have GBS is told, but here she had only myopathy. NCS was normal. Cardiac changes can be plus hypertrophic cardiomyopathy, but the echo was normal. Okay, so this was our first case, and I'll go on to the second case. I'll take. Okay. So second case was a 22-year-old female. So she was brought to casualty in an unresponsive state. And
Mohanakannan, 1 minute.
Sorry.
Just tell me about riboflavin. 400 milligrams. How do you manage to give 400 milligrams a day? What is the strength, maximum strength which is available, and how do you give it?
So actually, sir, in our hospital we have only 10 mg tablets, sir. So initially, we initially I gave them 5 tablets in the morning and 5 tablets in the night, sir. So the response was
100 milligrams.
100 milligrams, sir. But actually, I found in the reports that up to 400 or 500 gives better response. So there is one company which comes in online, sir, Ribofem. It's Ribofem, Ribofem, sir. RIBOFEM. That comes as a 200 mg tablet, sir.
Available,
Available, sir. It is available online. So they order online.
Oh.
Ribofem, that is the only.
Sorry?
Which company it is?
Sir, Ramkrishnan Petring, sir, it is available, sir.
Oh, yes, Ram. And cost?
Sir, ரொம்ப cheap தாங்க சார். 10 ரூபாய்க்குள்ள தான் வரும். ரேட் எக்ஸாக்ட்டா தெரியலங்க சார். பட் எங்க ஃபார்மசில இருக்குங்க சார். It is available.
200 milligrams is available.
ஆமாங்க சார், available.
Oh, very nice. Okay. That's informative. Thank you. But online means it Indian company தானா?
Sir, Indian company தாங்க சார். Indian company தாங்க சார்.
Okay. You're also talking of the same brand, Ribofem.
Yes, sir. Yes, sir.
Okay. Thank you. Where do you use it, Ramki?
Sir, இந்த மாதிரி கண்டிஷன்ஸ் எல்லாம் தாங்க சார். இது அப்புறம் நிறைய இந்த குழந்தைகள் வந்து ரைபோஃப்ளேவின் டிரான்ஸ்போர்ட்டர் டிஃபெக்ட் இருக்குங்க சார். அவங்களுக்கு யூஸ் பண்றோங்க சார்.
Okay. Thank you.
Thank you, sir.
I was interested because it is supposed to be a medication for migraine also.
Okay.
High dose of riboflavin.
Okay.
Thank you for prevention. Okay, thank you.
Okay. So, proceed, sir.
Yes, please.
So this is the second case. So this is the story of a 22-year-old female. So she is brought to casualty in an unresponsive state. And she was actually found normally conversing on the day morning with the parents, and she had breakfast. The parents had gone outside for some work, and when they returned home by afternoon, they found her lying in an unresponsive state. And so she was brought to casualty. And in the casualty, so all this happened in the afternoon, and she was taken to another hospital, nearby hospital, and then they just referred her. It was almost 6 hours by the time she had brought her to PSG hospital casualty. So there, she was found to have a very low GCS, 4/15. Blood pressure was around 130/90. She has tachycardia, and the saturation was low, 89% on 5 liter O2, and she was tachypneic. She was intubated in view of low GCS and desaturation. And post intubation, an MRI was done, and MRV. So all this happened prior to I had seen her. So all this happened in casualty. MRI brain and MRV was done the same time, and it was, the report was told to have sulcal hyperintensities and doubtful venous thrombus that needed a contrast imaging. So this was the report which was given on the day of admission. So they had given us abnormal sulcal flare hyperintensities, bilateral cerebral shears, query meningitis, and flare hyperintensity in left transverse and sigmoid sinuses. They wanted a contrast study. So the next day, the patient was in MICU, and she was admitted in general medicine. I was given a call over to see her for altered sensorium and abnormal MRI. Her examination, GCS was only 3/15, and pupils were 3 mm, is reacting to light, tone was flaccid in all 4 limbs, and power, there was no response to pain. Power 0/5, plantar was mute. So what I felt was there was no GCS. At the same time, the tone was very flaccid, and she had power was also 0. I felt there was both CNS and PNS dysfunction. So that is what I felt. The tone was very flaccid actually. So my thoughts were whether when thinking of both the central nervous system and peripheral nervous system dysfunction, I thought of whether it could be a meningitis, since the MRI was also showing sulcal hypertension, whether it was something like a meningitis with infectious radiculitis causing the peripheral nervous system dysfunction, or whether it was a snake bite because of the abrupt onset of all the symptoms with but that will not explain her CNS findings. Whether it is something like Bickerstaff encephalitis, but it was too abrupt for Bickerstaff encephalitis also, or some other poisoning, or whether there was 2 pathologies that are coexisting. So these were the first thoughts when I saw her. Further investigations, routine blood investigations, everything were normal. MRI brain with contrast was done, and that was also normal. There's no evidence of CVT or meningeal enhancement noted. EEG was showing diffuse delta range flowing, and CSF analysis also was done, which is non-contributory. So then I asked for NCS, and NCS showed something which is very revealed almost the diagnosis actually. So here the NCS was done, and it showed double CMAP or repetitive CMAPs. So almost all the motor conduction had double CMAPs in it. So the tibial, peroneal, all these things had double CMAP. So the double CMAP or the repetitive CMAP is usually seen in conditions where there is excessive accumulation of acetylcholine in the end plate. So usually it can be seen in congenital myasthenia, where there is acetylcholine esterase deficiency or slow channel myasthenia, or it could be seen in cases like OPC poisoning, where there is anticholinesterase is generated and acetylcholine is not getting regenerated and it gets accumulated. The other type where you get a repetitive CMAP is the neural CMAP, where these are all synaptic CMAPs. So in the synapse, there is more accumulation of acetylcholine, and it leads to repetitive stimulation of the junctions, and so there is repetitive CMAPs. While other is the neural CMAP, where the neural impulse itself is getting fired again and again. So as in the case of a neuromyotonia. So you can have a neural repetitive CMAP also. The other conditions, when the patient on myasthenia has a higher dose of Gravitar also, you can get repetitive CMAPs. So these are the common conditions you get associated with repetitive CMAPs. So it could be an overdose in myasthenia or OPC poisoning, congenital myasthenia with ACHG deficiency or slow channel syndrome. The other where you get or the familial paroxysmal kinesemia, and continuous myasthenia. The main things are the drugs in AMG, OPC, and the congenital myasthenia. This is where you commonly see. Further course, we did a pseudocholinesterase. It was low at 64. She was started on atropine paralleloxime infusion, and sensorium slowly improved. And she underwent a tracheostomy. And after her sensorium improved, she said by that when you asked whether she has consumed some poisoning, she accepted to it. And muscle power actually gradually improved over 2 to 3 weeks, and tracheostomy closure was done. And now she has come for second follow-up, and she's doing well. So here, the difficulties which I faced was sensorium was very low. Even if an acute flaccid paralysis, abrupt onset, I would have thought of snake bite or OPC, but sensorium being low, it can happen in a OPC poisoning. But it slightly confounded the picture, and there's no clear history of any poison intake from the family members. And initial MRI was also showing some doubtful venous thrombus and sulcal hypertension in such a setting. So it led to further diagnostic dilemma. But the NCS, I think, was very useful in picking up the coming to a conclusion here. I'll go to the case 3, sir.
The patient improved completely.
Any comments from anybody, unless there is a comment?
The patient improved completely with.
Yes, sir. Yes, sir. Yes, sir. Patient improved completely, sir. She has come for second follow-up. She's doing well. Tracheostomy closure has been done, sir. She had some problems with some personal issues, and she accepted to taking that also.
So she agreed to having taken OPC.
Agreed.
How much dose she took for Poisoning? How many tablets, sir?
That I'm not sure, sir. But she agreed to taking, sir. I'm not sure how much or what type of it. Not sure, sir.
Not clear.
Mohanakannan, you said about the pupils. Was the pupil reactive?
Pupils are sluggishly reactive, sir, actually.
3 millimeters only.
3 millimeters, yes, sir, 3 millimeters, sir.
But sluggishly reactive.
Sluggishly reactive, sir.
Any fasciculation seen in the muscle?
Fasciculations were not seen, sir. Not seen. Additionally, they had given some sedation and NM blockers also, sir. I was not sure whether, but fasciculations were not seen. I looked for it. It's not seen. I'll proceed to the case 3, sir.
Yes, sir.
Yes,
Can
sir.
you proceed, sir?
Okay, okay.
65-year-old male. He presented with headache of 20 days duration to. So this was in July month 2023. So a 65-year-old male. He presented to me with the headache, and it was 20 days duration, dull aching, continuous type of headache, which was non-disabling over his forehead and periorbital region. So he had history of recent family stressors. His sleep was normal. His fundus was normal, and there was no deficits. So since it was a 20-day duration headache, I treated it as a new onset headache. I wanted to rule out anything vascular thing. So I asked for a CVT thing. I wanted a MRI and MRV. So this was done in July. So this was normal. There was normal MRA, and the MRV was also normal. So I treated him like a tension type headache. I started my amitriptyline and asked to review in a month, but he didn't come back. He was lost to follow-up. So he comes back after 5 or 6 months in November last month. So 20 days back, he presented to me OP with increased severity of headache. And this time when he came, his eyes were swollen, there was redness, and diminution of vision also was a complaint. He himself had done a evaluation in ophthalmology outside, and they had asked for another diagnostic CT angiogram, and this was what came out. So this was his eyes when he presented to me. He had severe throbbing headache. He was not able to tolerate. His extraocular movements were also diminished, and his visual acuity was also diminished. So examination revealed swollen, congested eyes, right more than left. Extraocular movements were restricted on both sides. Pupils were reactive. No other deficits were noted. There was a bruit in his eyes on auscultation. So this was the workup which he had done outside. They had done a CT angiogram, and so it was suggestive of a carotid cavernous fistula. So ill-defined contrast enhancement in bilateral cavernous sinus and within the clivus. And so they had advised for a DSA. We admitted him. So ophthalmic opinion was sought, and his visual acuity was diminished in both the eyes. And so extraocular movement was restricted. It was told to be due to the congested chemosis. That is what their opinion was. And they had a corkscrew pattern of vessels noted, suggestive of increase in episcleral vein pressure. Fundus revealed flame-shaped hemorrhages, and there was blood in Schlemm's canal. And so what their opinion was, it was a CCF with secondary glaucoma and compressive optic neuropathy was their opinion. And we went ahead with the DSA. The DSA revealed a type 4 carotid cavernous fistula, and they were advised embolization procedure. So the types, I'll just go into it before so these are 4 types of CCF. So the type A is the direct one, where there's a direct connection between the IC and the cavernous sinus. So these are high flow fistulas. They're slightly difficult, as we went through the literature. So this is slightly difficult to close. So because they are high flow fistulas, high pressure fistulas, direct connection between the IC and cavernous sinus. The other 3 are indirect. It is the connection between the dural branches of ICA and the cavernous sinus. So if there is only connection between the dural branches of IC and cavernous sinus, we call it as type B. Only the dural branches of ECA and cavernous sinus, we call it as type C. If there is connection between dural branches of both IC and ECA and cavernous sinus, we call it as type D. So this gentleman had type D. He had connection between the dural branches of both IC and ECA and the cavernous sinus. So this is a relatively low pressure fistula. So the interventional radiologist, Dr. Ilango in PSG, he suggested to do a embolization procedure with PVA. So this was the procedure which he underwent. So I just show these pictures have been given by my interventional radiologist, Dr. Ilango in PSG. I thank him for that. So this is basically the arterial phase. of the ICA. So, so here you are able to see some ooze into the cavernous sinus. So this should not be visible, but it is coming leaking into the cavernous sinus here and the superior ophthalmic vein here. So it implies that there is some abnormal connection between the arteries and veins. This is an injection from the ECA, external carotid artery, and you can see already it is going into the cavernous sinus. Here you can see the cavernous sinus is getting filled. So there should not be any connection between the external carotid artery and the cavernous system. But here you can see the ECA is getting connected to the cavernous sinus. So here you can, the other phase, the delayed phase of the ECA, external carotid artery. So you are able to see the entire venous system getting filled up. There should not be normally any connection between the ECA and the venous system or the cerebral venous. So here it is getting filled. So it implies there's a connection between both ICA and ECA dural vessels with the cavernous sinus. So he did not have any trauma. So this is spontaneous CCF. And this is the lateral image showing the fistula. Again, this is the superior ophthalmic vein, and this is the cavernous sinus getting filled up. So this was when they injected the PVA particles, the embolization particles. And the post-injection, after the injection of PMA, now they are trying to inject into the ECA. Now it is clear the cavernous sinus is not getting filled in the arterial phase. So this was post-injection from the left side. And this was after 2 weeks of embolization. He came 3 days back post-embolization. And this was how much his swelling has reduced. And now his extraocular movement was almost full. The ophthalmic opinion was also short, and his visual acuity has also slightly improved. Headache was reduced. And he has also been doing, so this was only, the embolization procedure was done only to occlude the ECA dural branches. The ICA dural branches was not touched. And it was only minimal was what was told. And so to occlude the ICA low flow branches, what procedure has been advised to the patient was to do periodic 5-second occlusion of the ICA alternately. So that when the flow comes down, automatically the dural branches, low flow branches will close. So this is his case.
Mohanakanan,
sir.
The report which you showed that was
Yes,
clival changes as well as fibrous dysplasia. How is that related?
Okay, I actually truly I didn't go through that, sir, actually much, but I think okay,
because base of
go
skull
through.
involving left side, body of sphenoid
Definitely,
and
definitely.
could that have contributed to this fistula?
Yes, sir. He had a spontaneous CCF, sir. He was not traumatic, so maybe, sir, because of the enlargement of the fibrous dysplasia, whether it is just eroding into it, something that has to be looked into, sir. I'll definitely look into it, sir. Something I think I have missed it. I'll look into it. I'll ask the review of the images. I'll see if because if that is the case, then he's going to get it again. So I'll definitely look into it, sir. Thank you for the input, sir. Thank you.
He was normal for the first time, and second time was absolutely normal. You saw him first time.
Yes, sir. He was no visual symptoms. No visual symptoms. Fundus was normal.
Nothing.
There was no, sir. No.
So that was only a tension at take them.
No, sir. I'm not sure whether it was already whether we had done a CT angio at that time would have picked up. I'm not sure actually. So he came after 4 months with these symptoms. So I'm not sure whether it existed at that time, which was missed, and it was not a CT angio would have picked up. I'm not sure, sir. I feel more likely it would have been existed, sir. I feel if we had done a CT angio at that time also, we could have picked up it very early.
The swelling of the eyelids only helped us.
Yes, sir. Yes, sir.
Otherwise, you would have missed the case totally.
Yes, sir. I'll go into the case 4, sir. So
Yes,
this
sir.
is the 42-year-old male who presented to me with the case. It was a case of chronic DVT. He's treated elsewhere, and he discontinued treatment for 1 year. So he presented to neuro-OP with drowsiness, double vision, and drooping of both eyelids. for 3 days duration with mild headache. There was no fever. So his wife accompanied him, and she told for 3 days he was not responding properly. And she didn't give history of any double vision or drooping. They were not aware there was drooping or double vision at all. I mean, a double vision the patient was telling, but the drooping she was not aware at all. When I examined, so there was bilateral ptosis, and when I examined his leg, there was a very swollen, discolored leg, chronic DVT. He has not taken any anticoagulation for a long time. So examination revealed a drowsy patient who was arousable and he answered relevantly, was obeying commands. And GCS was E3, V5, and M6. Bilateral partial ptosis was there. And then there was left inferior rectus palsy and bilateral superior rectus or upgaze palsy. Pupils were 3 mm, sluggish reaction to light, no neck stiffness was noted. His power was good. He was able to walk. He was just drowsy. Investigations, routine blood investigations were normal. ANA was weak positive. ANA profile, ANCA profile was negative. APLA workup was negative. So this was the MRI picture. The MRI picture, there was a diffusion restriction. So it was actually restricting in the pictures here. It is not reflecting much, but it was restricting right thalamus and right paramedian midbrain. Also in the left paramedian midbrain, there was so it was opined as an acute infarct. Involving the right thalamus, right paramedian, and left paramedian midbrain. So we did a contrast study also. There was no contrast enhancement. Initially, I had asked for a contrast because he had cranial nerve palsy. I did not suspect it to be an infarct. I thought it could be an infarct. It could be a cranial nerve palsy also. So I wanted a contrast to see if there is any enhancement in the nerve roots. But this turned out to be a parenchymal lesion, and there was no contrast enhancement. And this was the FLAR image. So this was the MRI report. They told the 2 diffusion restriction lesion, right thalamus and bilateral periapical gray matter in midbrain. Their DDs were acute infarcts or Wernicke's encephalopathy or demyelination. So CT angio was done and it was normal. And basically, I think patient had a venous thrombus and he had posterior circulation stroke, and he was a young person. So we asked for rheumatology consult. They did a pathology test and it was positive. And we had also sent for HLA-B51 and it turned out to be positive. HLA-B51 was positive. So this is a case of Neuro-Behcet syndrome. This patient did not have any oral ulcers or genital ulcers, or he did not have any eye findings, or no iritis, uveitis. So we did an ophthalmological evaluation also. He did not have any eye findings also. He had only predominantly vascular venous occlusion in the lower limb, DVT, chronic DVT, and he had a lesion in the thalamus and brainstem. So whether this is a part of the parenchymal lesions seen in Neuro-Behcet's or it was an infarct, it remained. Usually the lesions seen in Neuro-Behcet's are in the thalamus midbrain, and they are said to be part of the meningoencephalitis, which happens in a Neuro-Behcet's. But here he had diffusion restriction also. But so the course, actually we started on oral steroid 1 mg per kg and colchicine, and started on a monthly pulse of cyclophosphamide dose. He was started on anticoagulation for his chronic DVT. Now he came for first review last week, and the sensorium is improved, but still the ocular palsy remained. He's due for second dose of cyclophosphamide next week. So Neuro-Behcet.
What type of anticoagulation?
Sir, sorry, sir.
What anticoagulation? What type was given?
Sir, Novax. Sir, I started him on newer dabigatran, sir. So Neuro-Behcet's, for this patient, he had a DVT, and whether it's a brainstem encephalitis or it is an infarct, I'm not very sure, but there is a diffusion restriction again here. HLA-B51 positivity was there and pathology test was positive. He did not have any oral genital ulcers and his ophthalmological workup was negative. So this is the criteria for the Behcet's disease. Ocular lesions, they give 2 points. Genital aphthosис, 2 points. Oral aphthosис, 2 points. skin lesions 1 point, neurological manifestations 1 point, vascular manifestations 1 point, and a positive pathology test is 1. So score of 4 or more indicates the diagnosis of Behçet's. Our patient had 3 neurological manifestation, vascular, and positive pathology test. So neuro-Behçet's manifestation can be various axes actually. Parenchymal manifestation, usually the brainstem is involved, midbrain, thalamus are the most involved areas. And the manifestation actually they say it's a meningoencephalitis or the brainstem encephalitis. And it can also involve the optic nerve, other cranial neuropathies. Cerebral venous thrombus can occur. Arteritis with arterial strokes and aneurysm can occur, and spinal cord lesions can also occur. So neuropathology of parenchymal lesions or the brainstem lesions is a lymphocytic meningoencephalitis with perivascular cuffing and inflammation of the adjacent parenchyma with accumulation of lipid-laden macrophages and areas of necrosis and gliosis. Perivascular cuffing arises around small veins. So basically the disease starts in the veins in neuro-Behçet's, and it can also spread to the arteries, what is told. This is my case 4, sir. If no questions, can I proceed to the case 5, sir?
Yes, sir.
Yes, sir. Thank you.
Sorry, more one question.
Yes, sir.
Why did you ask for a HLA-B51?
Sir, actually, it was he had a young stroke, sir, and he had a venous thrombus also. So both venous and arterial strokes were occurring together.
Yes.
So it was just on that basis we asked for a HLA-B51, sir. Young stroke workup, I think, vascular occlusions. That is what we had asked, sir. Actually, that was my suspicion, sir.
What did you have in mind? What, specifically, why HLA-B51?
Sir, I thought of Behçet's, sir. sir. Because the posterior circulation involvement, the midbrain thalamus involvement, one thing, and the venous occlusion for in a young patient, actually. He did not have any smoking or alcohol history. And so I thought of Behçet's, sir, actually, because he had a venous thrombus long-standing. He is a young patient. He didn't have any diabetic hypertension. He is not an alcoholic. Plus, he had lesions in thalamus and midbrain. I was not sure, truly on seeing it, I was not sure whether it's an infarct or it was a demyelination with diffusion restriction. I was not sure. Because the lesion was characteristically present in the thalamus and midbrain lesion area. And he had a venous thrombus also. So that is why I asked for HLA-B51, sir.
How old was he?
40 years, sir.
Thank you.
Thank you. So going on to the last case. So this is a 65-year-old female who presented to me with the history of left-sided headache for 3 months. So the nature of the headache was continuous dull aching pain. It increases at night, disturbs the sleep. Relieved with painkillers. No fever or vomiting was noted. She had one episode of GTCS 2 days ago. So this is past history. It was not very clear. This was given from a small note where her son had noted what had happened. So they had missed all the files, all the old images actually. So this was something her son had noted down, all these things in a small note. So this is what was available to me. So she had a past history of right optic nerve mass lesion 2 years ago. This was initially diagnosed as optic nerve glioma via MRI, but she underwent some diagnostic procedure. This happened in Arvind Hospital, and it showed inflammatory cells without evidence of dysplastic cells. She was put on steroids and Azaran for 1 year, and she stopped all drugs for the past 1 year. This was her past history. So examination, she was conscious oriented. Her GCS was 15. Her right eye visual acuity, only light perception was present, and it lies in adducted position. Ocular movements are restricted, absent actually. It was, and pupil was 3 mm. It's not reacting to light. Left eye was normally moving, and the fundus of the left eye was normal. There was no neck stiffness, no deficits noted. So then I asked for an MRI. So this was the MRI picture. Here you can see this is FLAIR image showing FLAIR hyperintensity is noted in left lateral temporal lobe and left high frontal lobe. So this was the contrast image. In that corresponding areas, we are able to see meningeal thickening. left frontal and left lateral temporal regions. So again, here we see left frontal and left lateral temporal regions. Dural thickening is noted here. Coronal section. So this was the report which was given. The MRI was done outside. So this showed diffuse pachymeningeal enhancement on our left frontoparietal temporal, bilateral basifrontal, and right anterior temporal regions. So they opined it is a possible hypertrophic pachymeningitis to be considered. So the workup was done and routine investigations were normal. ESR was 90. Her HbA1c came positive. HIV and VDR were negative. The other ANA autoimmune workup, ANA profile, ANCA profile was negative. Rheumatoid factor was negative. We went into the CSF. CSF analysis showed 20 cells, lymphocytes. MTB gene expert was negative. India Inc. negative. Cryptococcal antigen was negative. Meningoencephalitis panel was negative. And cytology was also negative. We went and we did a IgG4 level. That's normal. CT chest, we went ahead and there's no evidence of lymphadenopathy. AC level was normal. We went ahead and with the dural biopsy. So it turned out to be hypertrophic pachymeningitis. There was no evidence of granuloma or malignancy. So this is a case of idiopathic hypertrophic pachymeningitis. And so we ruled out Wegener's IgG4 related because IgG4 was normal. VDR was negative and the biopsy also was not suggestive of any granulomas. Tuberculosis was ruled out. There's no meningeal carcinomas. There's no abnormal cells noted in the biopsy. CT chest did not show any lymphadenopathy. And the other causes intracranial hypotension. So we concluded it to be a case of idiopathic hypertrophic pachymeningitis, and we started on pulse methylprednisolone. So right now she's getting pulse methylprednisolone. Today is day 4. We are planning to put her on long-term immunosuppression after pulse steroid. Rituximab might have been an option, but he had HbA1c positivity. So clinical features: headache. The commonest feature in idiopathic pachymeningitis, hypertrophic pachymeningitis, is headache. It can also present with cranial nerve palsies, and it can present with symptoms related to pressure effect on adjacent structures. So these are the DDs for hypertrophic pachymeningitis. I've already told. They've ruled out. So this is our team, without which all this work would not have been happened. Thank you.
Excellent case, but it's quite rare to make a diagnosis like this. You don't think of immediately on that line, but some optic glioma was seen some 1 year back.
Yes, sir. So actually, they had given the same, sir. Actually, the right diffuse atrophy of right optic nerve, retrobulbar fat stranding, and fibrotic strand. So whether that itself was another hypertrophic pachymeningitis or lesion which occurred there, and she was on immunosuppression for a year, sir. Whether that came down with immunosuppression is not. We don't have the treatment details, sir. Actually.
Can glioma go away like this with 1 year treatment?
So no, I don't think it would have been glioma, sir, because they had done a diagnostic procedure, I think, and it didn't show any malignant cells, sir. Probably the initial MRI, radiographically, they might have thought it of a malignant lesion, but I think the same, it would have been something like a meningeal thickening present. Yes, sir, with mass effect, yes, sir.
Some mass lesion, may not be glioma.
The same meningeal pachymeningitis itself could have occurred that region, sir. So that is what I think, sir, which has gone down with immunosuppression.
Oh, good. Somebody is asking whether it is related to pachymeningitis or just a correlation. There was a question in the board.
So whether it is related to pachymeningitis or
is it just a coincidence? Somebody is asking that question.
I feel it could be part of the same disease, sir, because the initial, I think they have, if someone has suspected a glioma, that means some lesion should have been there, which is almost absent now. And that means the only explanation is it has responded to the immunosuppression which has been given for a year, the steroids and azathioprine. So I feel it could be part of the same disease which has happened. And she has discontinued drugs for a year now, and now she's come back with again recurrence of headache.
No, the question was whether HBsAg is related or not.
So I went through the literature, sir. I couldn't find much correlation between HBsAg and this hypertrophic factor meningitis, sir. Actually.
Is there a correlation at all between HBsAg and hypertrophic factor meningitis?
No. As far as I searched in the literature, there is not much.
No, I don't know of any correlation between HBsAg and factor meningitis. We do come across a lot of this idiopathic hypertrophic factor meningitis, IgG4 is sarcoidosis. All these are routinely considered as differential diagnosis. We have done biopsies also. Sometimes nothing turns out to be positive, and patients, of course, have raised ESR, raised CRP. We've given, like what you said, ibimethylprednisolone, azathioprine. Some cases respond to steroids alone. Some cases require azathioprine. There are a few cases where we have given intrathecal triple therapy: cytosine arabinoside, methotrexate, and hydrocortisone. At present, there is one patient with us on follow-up with intrathecal triple therapy.
Okay.
All excellent cases, Monakannan. All cases where we learned something.
Thank you, sir. Thank you.
Learned a lot.
Thank you. Thank you.
Every case was difficult to diagnose. Every case was investigated properly. You presented very well. Congratulations. This really gives education to all of us.
Thank you, sir. Thank you.
We don't see a lot of acute meningitis like this. It's very not be common to have a acute meningitis presenting like this.
Thank you, sir.
And Raj, want to say something?
Sir?
Dr. Naraj wanted to say something?
Sorry. No. I just said, sir, I don't have anything to add unless somebody wants to add anything to whatever has been discussed. If not, Professor DRS, sir, you can conclude, sir.
Okay. Excellent discussion. Thanks a lot, Dr. Bala and team. That's what somebody is saying. Everybody is appreciating the whole forum. Extremely nice. Thank you very much.
Thank you.
Natarajan can give you a conclusion.
I thank Professor DRS and thank Professor Bala and Monakannan for those excellent cases. As I said, we all learned a lot from these cases. So I'm indeed thankful to all of you. I just wanted to say that next month it will be Vijay Shankar of Apollo Hospitals who will be presenting a series of movement disorders cases. So that will be next month. Date he has not yet told me, either 20th or 27th of Jan.
Chennai Apollo.
Chennai Apollo, Vijay Shankar, sir. He is a movement disorders man, sir. He is presenting a series of cases of movement disorders. And I thank, as usual, the Sun Pharma who has been supportive of all these presentations, all these meetings. And thank you once again, the Sun Pharma team. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir. And thanks all the audience for their active participation. Yes, thank you.
Thank you.
Thank you. So many people attended.
About 59 people attended, sir.
But not much from Madurai. That's the only thing.
From all over, sir.
Addition is there.
Yes, sir. Thank you, Professor DRS, sir. Thank you.
Thank you, sir. Thank you.
Have a good day, and
Thank
please
you,
try
sir.
to come over to Chennai update, sir.
Okay, thank you.
Thank you, sir.
Thank you.
சீக்கிரம் முடிஞ்சிச்சு 1 மணி